Good morning. I'd like to welcome everyone to DeBakey Heart and Vascular Center Grand Rounds this morning. We have a very special guest. She happens to be an anesthesiologist, a cardiac anesthesiologist, who knows Houston quite well in that she was an anesthesiologist at Texas Heart Institute for several years, as well as head of research over there during her tenure there. Dr. Nancy NUSSMEIER is well known in cardiac anesthesia, without question. Everybody knows her. She did some landmark publications, one of which I recall clearly when she was at the Texas Heart Institute had to do with cerebral protection and which drugs might be used to protect the brain when the patient is under cardiopulmonary bypass. Currently, she is physician editor of Up to Date, which I personally have not accessed, but I will. I understand it's a great publication that's readily available on the internet, and it does have anesthesia included now. Nancy is one of the two anesthesiologist editors. She's a member of the Department of Anesthesia, Critical Care and Pain Management at MGH, Massachusetts General Hospital in Boston, where she has previously been during her training. She trained at Mass General. She also previously held positions as professor and chair of the Department of Anesthesiology at SUNY Upstate Medical Center in Syracuse. And she was also director of cardiovascular anesthesia research, as I mentioned, at the Texas Heart Institute from 1999 to 2006. She served on the faculty at UCSF, San Francisco, prior to that. She has held several national positions, including service on the board of directors of the Society of Cardiovascular Anesthesiologists. It is an entity that has existed since the late 70s. Also, American Heart Association Leadership Council for Cardiovascular Surgery and Anesthesia, FDA, Anesthetic and Life Support, Drugs Advisory Committee. She is immediate past chair of the American Society of Anesthesiologists Educational Track Subcommittee for Cardiac Anesthesia, and she currently serves as vice chair on the Society of Cardiovascular Anesthesia Foundation Board of Directors. Over the years, she has been widely published. Her research, again, has been not only timely but very important. She has many peer-reviewed publications, abstracts, books, chapters, and so on and so forth. She's also on several editorial boards, including Associate Editor-in-Chief of Anesthesia and Analgesia Case Reports. That is our so-called Yellow Journal. It's one of the two major publications in anesthesiology. So Dr. NUSSMEIER, welcome to Houston. Welcome back to Houston, I should say, and we're looking forward to your presentation.
Thank you. I'll try to live up to that glowing introduction. It's really an honor to be here. The program that you've put together for your visiting professors is just extremely impressive, as is your institution, and it's always just a tremendous pleasure for me to be back in Houston. So I'm very appreciative to Dr. Herrera, Dr. Naples, all of you for the invitation. So this is going to be a really different talk, I think, from what you're used to, and hopefully you'll enjoy it. I do have some video movies to show examples of poorly done and well done vignettes from that relate to what we're going to talk about. And so I've tested them, they play well, and it should be fun. I have nothing to disclose except being an employee of Up to Date. Anyone in the room under 35 probably knows all about Up to Date, not necessarily those older, but ask somebody 35 or under, any physician, they can tell you. And in the interest of full disclosure, I'm not really an expert in patient safety, at least not based on any research in the operating room on teamwork and communication. I got interested in this when the American Heart Association commissioned a writing group to do basically a review article, a scientific statement on the state of the art in 2013. And the authors on this paper are in part cardiac anesthesiologists, but you'll recognize, you'll recognize the names of many cardiac surgeons, as well as perfusionists and human factors safety engineers, and even the American Association of Perioperative Nurses was very involved. And from a professional society standpoint, the Society of Cardiovascular Anesthesiologists, the Society of Thoracic Surgeons, the American Society of Extracorporeal Technology, which is the perfusionist equivalent of the STS, the Society of Thoracic Surgeons, or the SCA, they are the ones who actually, thank you, they are the ones who actually put together the videos that I'm going to show you, although, again, it was with participation from these other societies. So our writing group for that statement learned that much of what we're already doing to improve patient safety in the heart room, and perhaps could do better, is based on principles of communication and teamwork. For example, there's good evidence that one form or another of all the interventions listed on this slide do improve outcomes within an institution. So I'm going to talk about the practical things that are or should be done by clinicians in the trenches every day. And I'm also going to mention some institutional initiatives, such as team training and simulation training, that have probably made a difference in many institutions. Some of these things overlap, as you'll notice on the slide, like checklists are really a short form of a briefing, but a true in-depth briefing, or some institutions call it a morning huddle, is probably optimal. So these tools really do improve patient safety, although I think it's taken a while for most of us physicians to realize it. And I personally hate to admit it, but I'm getting to the age now where I find myself thinking the things on this slide. And I'm sure that my surgical colleagues feel the same way on many occasions. So timeouts, we all know about timeouts. They're just a hard stop in the action to be sure that things are the way the patient believes they should be in the preoperative timeout, and that things are the way the team understands and believes they should be in the pre-incision timeout. Oops. There we go. And in some institutions, there's an additional 1 or 2 timeouts that are done during the case, particularly in the cardiac operating room. It's not the same information that's transmitted, but in many institutions, there's a timeout just before going on bypass and another one just before coming off bypass to make sure that everybody's ready. They do actually do that at MGH. Checklist. Everybody knows about these too. They're cognitive tools that can help teams make sure they've communicated and that every step in a complex process is completed. The WHO surgical safety checklist, or a variant of it, is used now in most operating rooms and in most countries. But what I want to point out is that this WHO checklist actually does have some components of a briefing. The queries about the anticipated critical events that are asked of the surgeon, the anesthesiologist, and the nurses. And it also has some of the components of a debriefing in that at the end, there's an opportunity to discuss key concerns regarding management during the case and whether there were any equipment problems. There are a lot of studies that have shown that the use of checklists do generally improve outcomes. They're not totally consistent, but the plethora of the data shows that they do. This one's just of interest because it was just published this month. It's global, so it includes a lot of institutions throughout the world. It included 500,000 patients in this meta-analysis, and showed that exposure to a checklist was associated with both reduced postoperative mortality and reduced complication rates. But it's probably the briefing that's the most valuable component of the WHO checklist, and that's what I'm going to show you in the first video. You may be asking yourself, what is the difference between a checklist and a briefing? And Tor Sant, the cardiac surgeon who appears in the video in a couple of minutes, I think has explained it very well. As he says, checklists are always the same conversation every time, the same thing. Briefings are always different from one patient to the next because they are patient-specific and they are procedure-specific. So I'm now going to show you an example of a briefing. This one is poorly done.
Denise, I thought the surgeons were going to be down here for this. We're going to do some huddle or something now?
Yes, that's supposed to, and they know they're supposed to be here. Just let me finish this count and I'll call them. You go through this every day.
8, 9, 10.
Okay, just do your hypos and then we'll,
1, 2, 3, 4, 5, 6.
all right, I'll call them now. Go through this every day.
You can show them later. I think this was done in McGilvery's room. I think he was out of town and they filmed this in his
He's on
room.
his way. Jen, it's Denise in 46. We need you down here for the briefing. All right, thanks, bye. They're both on their way.
I'll be in the pump room.
So let's finish the count. I'm waiting for that.
2, 4, 6, 8, 9, 10, 14, 15.
Okay, can we get this this briefing going? I've got patients in the office waiting for me. I've got sick patients in the ICU.
Okay, let me get Bill. He left the room while we were waiting.
Listen, Marissa, he is the annular shaped ring. He's got a low EF, we need a balloon pump, and we use Delnitoplegia, okay? Listen,
Okay, Bill's on his way. Bill's on his way.
Endocarditis case tomorrow, prosthetic endocarditis. He's 85, he's got a bad ventricle.
Are you guys talking about me?
No, we're not.
I'm sorry, we forget. We're talking about something
We're
else.
concerned about his mitral valve as well, so we need to have a good echoes to.
Okay, so Bill's here. Let's go. Can we get this briefing going?
Yeah.
Everybody listening? We're going to talk about you for a minute. This is about you. So this is Mr. Grace, medical record 0103466, and he has an allergy to penicillin. So what are we doing for procedure?
We're doing a mitral maze cabbage.
Okay, what type of valve?
We're gonna repair the valve.
Do you need anything special for equipment or
I don't think
implants?
so. No, we'll do it
Any
like we
critical or
always do.
non-routine steps?
I hope not.
Any airway concerns?
Nope.
Okay. Any antibiotics?
Gonna give him.
Just remind you, he's allergic to penicillin. Anything special for bypass?
No.
I have to check if we have blood, I forgot, I'm sorry.
No. But when you got all that stuff figured out, I got a lot of patients up in the unit.
Forgot.
Post-op from yesterday, sick. Call me when you're ready for me.
Okay, I'm gonna call about the blood and then we can finish the count.
So you just saw an example of a briefing before cardiac surgery operation. And you can tell that the team there is pretty frustrated with how it went through a number of behaviors and actions. Now, briefing in other industries is really common, and I've observed teams in transportation, the energy sector, and other high-risk industries where they routinely talk about the task at hand today or the case that's about to come up before it happens. And even if things are going to go really well and there's no anticipated problems, it's still a really great way of sharing information, perhaps bringing up some inconsistencies and resolving challenges. Now, in this briefing we just observed, the team's frustrated, and we can tell that the surgeon really wants to get this over quickly, and his hurry-up fashion really undermines the value of the briefing for the other team members and means that other people can't really contribute well. The perfusionist leaves the room before the surgeon arrives, and during the briefing is checking lines, which means that he is not really offering himself as being available or present and might miss some critical information. Other members of the team expressed their frustration verbally in that the circulator says this happens all the time, and the surgeon and anesthesiologist are discussing difficulties with another patient over an awake patient as part of the briefing. They're clearly not paying enough attention to the patient on the table at this particular moment in time. Other non-verbal behaviors are interesting. The surgeon looks at his watch during the briefing, which is pretty classic indication that there's something else more pressing going on that I need to attend to. The main question is, do these team members leave the briefing having had any challenges or concerns they had resolved, and do they leave with a better shared understanding about this patient's plan for the operation or not?
So the point is that a briefing or huddle can work to improve patient outcomes only if the team buys into the concept and does the adaptive work, not just the technical work, to make it valuable. And if the checklist is imposed from above, for instance, by hospital administration, without a team-wide willingness to accept change, without kind of a cultural change, physicians can end up feeling that the checklist or briefing undermines their authority and just delays patient care. And this one, was a good example of one that was probably imposed from above. But the briefing's really a chance for the OR team to share information, to bring up inconsistencies and resolve challenges. And ideally, it's performed with all members of the OR team present, the surgeon, the surgical assistants, the anesthesiologist, the perfusionist, the circulating nurse, and the scrub nurse. And this was a checklist used at Mayo Clinic. It was a few years ago, so I'm sure they've modified it now, but this is a good example of a cardiac surgical specific briefing tool, actually, where each person was involved, each person in the room on the team participated in the briefing. They actually used something similar to this at Mass General in the current era, it can be tailored to a given institution as far as the specific information that you want to glean from each of the surgical colleagues. So let's take a look now at a pretty good briefing, and this is just an example. They actually do it with the patient awake at Mass General, not necessarily gathered around the patient anymore. That's changed a little bit, but this is the way, this is a better way than what you just saw.
Morning, Denise.
Morning, Dr. Sun.
Mr. Chris, we're just going to talk about you for just a few minutes, so we're all on the same page and take good care of you, okay?
Great, thank you.
So at 7:15, we can start our briefing, everybody's here. So my name's Denise, I'm gonna be circulating.
My name's Bill, I'm the perfusionist today.
My name's Jennifer, I'm the PA, I'll be first assisting.
I'm Dr. Sunt, we know each other, I'm the surgeon.
I'm Doug Shook, the anesthesiologist.
Hi Kevin, I'm Marissa, I'm the scrub tech.
Okay, so this is Kevin Grace, hospital number 010-3466.
Yes, agreed.
So, and Kevin's allergic to penicillin. He gets a rash.
Yes,
So-
he does.
Okay, so what procedure are we gonna do, Dr. Sun?
So we're gonna do a mitral valve repair, cryo maze, and a cabbage ×3.
Okay.
We're gonna use the Lima to the LAD.
And he had a bilateral lower extremity vein stripping in the past.
Yeah, I'm sorry I wasn't booked that way. I
Okay.
didn't appreciate that until Jen picked that up out in the holding area. We'll use the REMA as well as a radial artery for the other grafts.
Okay, so if you wanna mark his arm, it might take a few minutes for us to get the supplies up from Central Supply for the radial artery.
Right.
Beyond
I'll
test
tell
was
him to put a
negative
rush on it too.
in pre-op on the left.
Okay.
So I'll tell him to put a rush on it too. So would you like the annular shape rings in
Yeah, that'll
the
be-
repair?
That'll be fine.
Two.
Use the annular shape ring for the mitral repair. If we're unable to repair the valve, we'll use a mechanical prosthesis.
And that's what you agreed with? You wanted to have done for you, Kevin?
Yes, thank you.
So any other special equipment besides, you want the cryo maze in the room?
Leave the cryo maze.
Okay.
His ejection fraction's a bit low, so I think we ought to have a balloon pump in the room, and we'll put a femoral heart line in on the field once we've got it corrected here.
Yeah, he'll take a 40 cc balloon, we have that on the shelf, and I actually have a console in the room already.
Okay, great. So any airway concerns?
Yes, he may be a difficult intubation, so we have a fiber optic scope available just in case.
Okay, any antibiotics, since he's allergic to penicillin?
Yes, we're going to give, instead of penicillin, we're going to give vancomycin 1 gram.
And what about Amicar?
So we will use Amicar for the case. In addition, we put a right radial arterial line in anticipation of the left radial heartus when I spoke to Jen in pre-op.
So as far as perfusion goes, you got his height and weight?
Yeah, so he's 165 centimeters, 65 kilos, which gives him a BSA of about 1.7. Target flow rate will be 4.1, so we're thinking a 21 French arterial and bicable venous cannulation with 224s.
I can put a larger pipe in the IVC for you. We can use a 24 in the SVC and a 28 or a 32 in the IVC, and then you won't have any trouble with your venous return.
Okay, do you want an LV vent?
I think we can just use a drop sucker.
Okay, thank you.
Antegrade, retrograde?
Let's give antegrade cardioplegia, we'll use Delnito.
He doesn't have any cerebral vascular disease, so I was planning to keep his pressure around 60, and we'll be cooling to 34 degrees.
Okay? That should be fine.
His pre-op crit is 36, so post-dilutional?
Yeah, post-dilutional crit will be 22, so I think we should have 2 units ready to go.
I ordered 2.
Okay, great.
Without
I
telling
will,
you, just to have it ready.
okay, thanks. I will wrap him, and I'll have a hemoconcentrator ready as well.
Be
Okay.
nice not to transfuse him if we can help it.
Agreed, let's wait till we get on bypass and see
Yeah.
what the crit is.
But I'll just have it in the room, just so we know. Anybody else got anything they want to bring up or discuss? Okay, that's great.
Okay, thanks. So let me know when you're ready. I'll
Yeah,
be
okay,
in
Bruce,
my
when we
office.
start, after he's asleep, and I position him. You're gonna go sleep, we're gonna take good care of you.
Thank you.
So you saw a different briefing there, and let's compare that briefing with the previous briefing. Now this one is not perfect, but it's certainly some improvements over the last briefing. And you can tell instantly the tone that the surgeon sets when he enters the room and the pace means that he's really giving the respect to the briefing that it deserves, saying this is an important activity that we should all do together. And the language used really creates a culture of communication and sharing that will set the team in good stead. Now this briefing has given team members the opportunity to cross-share information and to check that things are as they should be. And you can see that people are offering or speaking up about things that they're concerned about and things that they think other team members should know about. And this breaks down silos between professional groups, and so there's more chance that this team will work in a collaborative, cohesive way later in the case. And in fact, you can see this if you think about Bill now compared to the last briefing, the bad briefing. In this briefing now, I think we're more confident that Bill can speak up if things are not going well, or if the pace of the operation is not right, or if it's something he's not so sure about, because the briefing has given him the foundation to do that. And the real key here is to do this consistently before every case in this kind of manner. This is not a once a month or once every 6 months task. Doing it consistently will create and reinforce this culture of communication. Just to finish, it's important to point out that this briefing only takes a few minutes at the start of the case, and other industries do this routinely for every case because they know that when people have a shared mental picture about what is going to happen and have shared their concerns, there is more chance that errors will be picked up during the case and more chance of successful performance.
So at this point, I really do need to give credit to AMSECT. I don't know that everybody's familiar with that, but that's the equivalent society for the perfusionist, for the, the equivalent to the Society of Thoracic Surgeons. And although the Society of Thoracic Surgeons and the Society of Cardiovascular Anesthesiologists was very involved in the creation of these videos, it was really AMSECT that took the ball by the hand.
Can I say one thing too? Is that, it gave the surgeon actually more of an opportunity to lead, because when they were talking about what was going to go into the IVC, I mean, he was able to say, oh, actually, I can give you a bigger pipe. And so it didn't take anything away, right?
Right. And this is really the chief of cardiac surgery at Mass General. As the actor, it's one of my colleagues at the Brigham, Doug Shook, who's the cardiac anesthesiologist. There's real nurses and real perfusionists at Mass General. And the organizational psychologist, who is hired by the Department of Surgery at the Brigham, is the narrator, Stephen Ewell. He's also a human factors safety engineer. So the goal of a good briefing is actually to decrease disruptions in surgical flow, and flow disruptions do occur. They could be procedure-related, equipment-related, patient-related, but if the potential major things are identified early in the case, not only are patient safety issues and outcomes potentially improved, but the upfront communication may result in better efficiency in the long run. So let's turn now to surgical flow disruptions that can be annoying or even dangerous during the intraoperative period. Distractions and disruptions occur just with remarkable frequency in any cardiac operating room. It's been studied, and there are 30 door openings every hour. There are 1.2 alarms going off every minute. You all know this. These things add up. The alarms, the door openings, the conversations, even music can cause disruptions in surgical flow. And they're little things, but it has been shown that they can cause small technical errors, and those can add up to impair the surgical team's ability to compensate for an unanticipated major event. So there are things that can be done to minimize distractions that are listed here, and probably the most important single thing, though, is the general caveat to be cognizant of the mental workload of each team member at any given time, and that varies. If you have good situational awareness, you know that when the anesthesiologist is really busy, the surgeon may not even be there. There's not that much for the surgeon to do, and vice versa. When the surgeon's most involved in the technical aspects of the procedure and we're on bypass, that may be a relative downtime for the anesthesiologist. So being cognizant of the others and having situational awareness turns out to be key. So here's an example of a poorly handled and potentially disastrous initiation of cardiopulmonary bypass. The reasons for the near disaster include multiple distractions and flow disruptions, but also hearkening back to what I said earlier, there was a failure to do a second timeout or use a checklist before initiation of bypass, and the perfusionist had completely skipped the briefing, which led to some critical errors. In general, very poor teamwork.
For cardio?
It's getting slammed.
Give the heparin, please.
Okay, heparin's in.
Okay.
I know, we did one of those. but
You ready for first
Bill,
thing,
can I
please?
hand you this?
But thank God it was wrong. I can't believe, I know, our lungs are flawless. Yeah, because, right. So we have the lung transplant call, a heart call, regular call, and then PD calls. We can do the PD cases.
Oh, I'm sorry, I clamped your lines.
Oh, no worries.
I'm sorry.
Okay. Knife and a arterial cannula, please. Bird, please. Okay, you've got your arterial line.
All right, thanks, I'm
First string for the SVC. Pick up. Pump sucker, please.
Okay, suckers are on.
Where's your pump sucker at? Okay. Knife, SVC cannula, please.
Bill, the pressure's a little bit low. Can you give 100 in through the arterial
Yeah,
cannula?
sorry, I was just about to ask you about that, I apologize. Yeah, well, we're rapid, so.
Stitch for
Oh,
the IVC.
Here, here's your blood gas, Bill.
All right, this is just after
I
everyone.
didn't realize that. Let me get some phenylephrine running.
Great, thanks.
Okay, you've got your venous lines.
All right, thanks, I'm gonna vap that now.
Yeah, pressure's still really low, given a lot of neo here.
And I'm taking the venous line, I'm almost done.
You go on bypass.
Yeah,
go on
yeah,
bypass.
hold on 1 sec. Okay, going on bypass, going on bypass.
Let's go on to 34 degrees.
Okay, on bypass.
All right, run your cardioplegia up.
Okay.
Let's go. Come
One
on,
moment,
this guy's
sir.
an
Sorry.
old guy. He's got bad kidneys. We need a short bypass run. We do it
All
this
right,
way every
come on.
time. Come on.
Flushing the cardioplegia.
All right. All right, that's good.
Okay, plegia's off.
Drop your flow.
Flat down.
Clamps on, back up, up.
What was the ACT?
1 sec. Running plegia. Oh, is there a clamp on that line?
Yeah, I didn't even ask you for the plegia
Oh,
yet.
sorry. Oh,
Come on, let's get some cardioplegia going.
okay, sorry, thank you.
That's 92.
What'd you say the
So what-
ACT was?
Yeah,
Oh, hold on. 280.
Well, that's a problem.
Give him some heparin.
How much are your plegias in?
That's coming up on 500 there.
This Del Nido's good stuff, isn't it?
Del Nido.
Yeah, Del Nido cardioplegia, that's what we said we were gonna use.
This is not Del Nido.
Well,
sir.
why didn't
I
we do the
apologize.
briefing?
Oh, I wasn't.
We
I don't
talked
think
about
I
it in
was
the
here
briefing.
this morning for the briefing.
Yeah, we said it.
We did.
I must have stepped
Maybe,
out at that point in time, sir. I apologize.
All right, the heart's full. Is your drainage all right?
Let me turn on my vacuum here.
Because the cannula position's fine.
Okay, the heart's all arrested, plegia's off. You know, my drainage is not very good. The vacuum didn't help my drainage. Can you check
The
the
cannula's
pH?
fine and the heart's empty.
Okay.
Bill, are you doing something about that pressure?
You know, I can't bring my flow up any higher than an index of like 1.4 right
Well,
now.
just turn your suckers on. Turn your suckers all the way up.
Suckers are all the way up, sir.
As we join this operation, we can see that the team is not in sync right at the start. There's a conversation between the perfusionist and the circulator that's separate from the other members of the team. And actually, this is okay, but it means that our perfusionist is not really able to gather information about what's happening. So doesn't hear the fact that heparin is going in. The scrub practitioner tries to give him lines and he doesn't hear her and can't see her. So he's physically detached. And he's actually there, present, but mentally he's not up to speed with the progress of the operation. This is not critical at this stage, but it does have some impact later on in the case. And we can see that when the anesthesiologist suggests that the pressure is a little low, Bill's language then is, you know, I was just going to ask you about that, and I didn't realize that was happening. So in his language now, there are some low signal cues that he's not completely up to speed with the operation. He's falling behind. And this could be the impact of the poor briefing that we saw earlier, the fact that he's really still trying to tune into what's happening in the operation. Now, this is a critical point for other members of the team, the anesthesiologist, the surgeon, the scrub practitioner, because by paying attention to the way that Bill, the perfusionist, is saying these things, means that it gives them an indication that a critical team member is perhaps not on the same page, and they can then intervene and say, do you need some time to catch up, or how can we help you, or how can we regroup? But that does not happen. And actually what does happen is that with the pressure to proceed with the operation that the surgeon is now placing on the perfusionist, he makes a call to go on bypass. It's not something that he would really do in real life at this stage. And it's the equivalent of trying to jump the plane over the glide slope when he's coming in too fast and too low to land. And what ultimately happens here is that Bill becomes a high-risk individual in the team. When the anesthesiologist asks him for the ACT, he's really overloaded and freezes. In fact, he's so overloaded with different tasks, his working memory is at full capacity, and he can't speak. He can only give a hand signal. And at this time, really, this is a high-risk individual that is potentially going to harm the patient by not being up to speed with the rest of the team. To close with, cardioplegia was particularly troublesome in this situation. The perfusionist had the wrong type, was not ready to give it, and then gave it early before the surgeon had asked for it. And so we can maybe trace back the reasons for this to the briefing. Now, the briefing might have solved some of these problems, because if you remember, the perfusionist wasn't ready when cardioplegia was mentioned. And in fact, the anesthesiologist effectively throws the perfusionist under the bus at the end of the case when the surgeon is standing with his open arms saying, what's happening? The anesthesiologist said, we said it.
So this vignette also shows, I think, the value of something we haven't talked about yet, which is structured communication, at least during critical periods. Examples include initiation of bypass, coming off bypass, during the briefings, during handoffs in the ICU. We aren't going to get that far in the talk today, and certainly in the management of crisis situations. An example of structured communication is closed-loop communication, or speak-back, meaning that the sender clearly identifies the intended recipient, who then repeats back the message is heard, and the sender acknowledges this. Normally, we hear this in many of the interactions with our perfusionist colleagues. Communication errors, though, can occur when the information is sent incorrectly, when it's heard or interpreted incorrectly, or when the intended receiver thinks someone else was intended. And certainly, elimination of jargon and slang, although I think we all have enjoyed it, reduces the chances of error during critical periods. It turns out that closed-loop information is particularly important when teams are unfamiliar with one another. I know there are teams here in this institution that have worked together for decades, and perhaps it's less important in that setting, but it's been studied, and it's particularly important when there are team members who have not been part of that group for ages and ages. And hopefully I won't seem too politically incorrect if I say that this clear two-way communication may be especially important when English isn't the first language of every team member in the room. Respectful communication has also been looked at, and I think it is very important that we maintain respect for the other surgical team members during all of these communications, and that they maintain respect for us. The key words are politeness and professionalism. This has actually been studied. This article was published last year in the Annals of Surgery, where they surveyed every single hospital in South Carolina. And it's interesting because just the perception of whether or not communication was respectful in the operating rooms in every hospital in South Carolina correlated very well with the death rates of that hospital. So let's look at a better initiation of cardiopulmonary bypass.
Pericardial stitch, please. Could you give the heparin, please?
Okay, 21,000 units of heparin going in at 8:45 a.m.
Okay, thank you. That's 21,000 units of heparin at 8:45.
Bill,
Yes.
here's your ACT sample.
Great,
Can I have
thank
the
you.
aortic purse string, please? Can I divide your lines?
You know what, Dr. Stunt, the ECT just stopped at 280 seconds.
Okay.
I recommend giving another 10,000 units of heparin.
Okay, Bill. 10,000 units of heparin just went in at 8:58.
Thank you. That's 10,000 units at 8:58.
And 3:15 you're before bypass.
Okay. Dr. Stunt, you may divide the lines.
Thank you.
Bill,
Yes.
I have another ACT sample for you.
Great, thank you so much.
Are you ready to cannulate?
One moment. The ACT is 400 seconds and rising. We are okay to cannulate.
Knife, please. Cannula. Okay, you've got your arterial line.
I got a good pulse down here. I'm gonna test the line. Okay, good line pressure. Line test is good.
Bill, pressure looks good.
Wrapping now.
Stitch for the SVC. Can we have the pump suckers, please?
Suckers are on, sir.
Good. I'll give Neo if necessary to keep the pressure stable.
Okay, thanks. Yeah, blood pressure stable with a mean of about 80.
Line for the
Suckers are on.
SVC handle, please. Stitch for the IVC, please.
Wrap's going well. Mean of 70.
I haven't had to give any Neo yet.
Okay, thanks.
Line for the IVC handle, please.
I'm gonna hold on that wrap for now.
Okay. Okay. You got your venous line?
Okay, thanks.
So Bill, the pressure's dropped to about a mean of 50. I'm giving some phenylephrine.
Okay, perfect. I'm gonna start to VAP just a little bit, see how much I can get off here.
Giving a little more phenylephrine.
Okay, thank you.
Total of about 80 mics so far.
Okay, you ready for
All
bypass?
right, you know, yeah, I've stopped VAPing just now. I'm done with the prime. ACT is 480 seconds and still going. Arterial and venous cannula positions look good, and we're going on bypass.
34 degrees, please.
Okay. Okay, coming up to full flow. We're at an index 2. We are cooling to 34 degrees.
Frank, you want to turn your lungs off?
Okay, lungs are off.
Flush your cardioplegia to me, please.
Okay, flushing cardioplegia. Gas is on, Doug.
Thank you.
How's your bypass?
Bypass is good. My venous return looks good.
The heart looks a little full. Let me adjust the IVC cannula a little
Okay.
bit.
Oh yeah, my
Does that
levels.
get you some drainage back?
It did, sir. Yes, my level's getting a little better there.
Otherwise, you ready for a cross clamp?
Yes, sir. Bypass looks good. Oxygenation is going well, and I think we're okay to cross clamp.
Okay, drop your flow to 500, please.
Load on at 500, sir.
Clamps on, back up, deliver your plegia antegrade, please, 800 cc's.
Yes, sir. The flow is coming back up to an index of 2, giving antegrade cardioplegia, 800 cc's total. Flow looks good.
The root feels fine.
Okay, great.
Give us 800 cc's and then let me know again every 15 minutes.
Yes, sir. We'll do 15 minutes on the update. Okay, that cardioplegia is going great. 9 degrees C is the temperature. We're coming up to 800 cc's total. That's 800 cc's of cardioplegia. I'll let you know in 15 minutes, sir.
Thanks.
So that was an improved example of initiation of cardiopulmonary bypass. And what's important here is that we know right away that the team is in synchrony, and there's a lot of task-relevant and patient-centered communication. There's not too much communication. People are not describing everything that's happening, but it's certainly not silent. So we know this is a team in synchrony. And I use some of the non-technical skills, taxonomies such as knots and ants to really try and pull out the behaviors that underline this. And we can see using those systems that situation awareness behaviors are really clear and improved here. So level 1, gathering information, level 2, understanding, and level 3, predicting what's going to happen next. And there are several examples here of closed loop communication during heparinization, initiation of bypass, and cardioplegia delivery. And finally, there's also a layer of politeness here. People are saying please and thank you, and there's a warm and fuzzy feeling in the OR, which is great, and that's a really important aspect of professionalism, but it's not a replacement for good communication, and it's not a marker by itself that the team is working well.
So team training may help with some of this, and there have certainly been studies looking at team training. They initially were kind of based on the crew resource management techniques that used in the aviation industry. One problem with team training, efforts like team steps, is that studies have shown that if you do it once and you get improvements, and 12 months go by and much of the improvement is lost. We don't really know yet how to sustain improvements, and that's an issue for future research. There has to be some ongoing effort to get the sustainability. Simulation training is another superb way to do teamwork training and to practice these communication skills, and a lot of work's been done with simulation to teach technical skills like robotic surgery and airway management and anesthesia, but simulation can also be used, and this is an example of simulation, to teach and test non-technical skills such as clear communication during catastrophic events. So I think we have time for a catastrophic event here.
I'm seeing ST changes on the ECG, and so it looks like he's getting a little ischemic, and I cannot maintain his blood pressure. It's down in the 40s.
Okay, well, we better get on bypass. Give the heparin, please.
21,000 units of heparin is in the patient.
Thank you. That's 21,000 units of heparin in the patient.
Okay, let's get a knife and arterial cannula. Hold on to that, Jim. I'm going to divide your lines. What's your ACT?
Okay, ACT is coming up on the 300 and rising. Thank you. You made the ACT was a 280. Yeah, good.
Okay, just an update, our pressure's still in the 40s with ST changes.
You have a stitch for the venous?
Okay to test the heart line?
Yeah, please test it, yeah.
Line's okay.
Okay, thanks. Knife and a venous cannula, please. All right. You got your venous line now.
Okay, thanks. We're going on bypass.
Okay, ventilation's off.
How are your ST segments?
Still up, still up.
All right, let's get him rested. What's that pressure? What's that alarm?
Circuit alarm. I'm checking it out. I think we're okay. Let me just re-zero the transducer.
What's going on? The guy's ischemic.
I
He's
know,
pretty
I know.
ischemic and he's
What's that
hypotensive.
Debriefing? Right greater than the left?
Yeah, so
Help, Bill?
What's going on?
my pressure's high. I re-zeroed the transducer.
Your
I
pressure
think
can't
it's a
be
real
high. The
pressure.
pressure's 40.
Well, I can't flow higher than 1.5 liters a minute right now.
Let me get you some help.
It's my arterial line pressure. Is there any kinks in the field?
I don't see any kinks on the field.
Okay, I don't see any down here
So
either.
the aorta looks blue. The aorta is blue and hard. Doug, do we have a dissection? Can you look at the echo?
Yes, there's definitely a flap in the ascending aorta. There's definitely dissection.
Okay, let's blow in the lungs, leave some volume in on the venous side, come back off bypass,
Off
and
bypass.
change our arterial cannulation to the groin.
46 by weight mechanical.
Yeah, we're gonna cannulate the femoral artery.
Okay, we're ventilating. Blood pressure is still low.
I need a knife and a femoral arterial cannula,
Okay.
please. Knife? Okay.
I'm filling up to the venous line.
Looks like the blood pressure's coming up, Bill.
Okay, thanks.
Let me know if you see a wire in the true lumen of the aorta.
minus 60 on the patient.
Okay, I do see a wire.
Okay,
It's in the, it looks appropriately placed.
all right, all right. All right, Jen, get that arterial line divider out there. Tubing clamp? Heavy scissors? You get it?
Got it.
Great, okay. Work. Okay, go back on in the groin,
Going back on in the groin.
cool to 18 degrees.
Cool at 18 degrees.
Ventilation's off.
So as we join this scenario, it's clear the patient is not doing well and there's a hurry to get on bypass. The perfusionist hasn't tested the arterial line properly and agrees that we're ready to go on bypass. And this creates a whole set of conditions of confused communication. And this communication is all about the pressure. And so when there is a problem and the surgeon asks what is wrong, he is seeing a drop in the patient's blood pressure, but the perfusionist is fixated on the line pressure. And this mismatch of mental models about what pressure we are discussing delays identification of the real problem. Now, the perfusionist can fall into a couple of key error traps here. By fixating on the line pressure and not trying to understand what's the bigger picture of the problem, you can go down a path of trying to fix the line pressure when actually that's not the source of the problem. So the other potential is for confirmation bias. And at one point, the perfusionist assumes that his transducer needs to be zeroed, and that's the source of the problem. And he is looking for information that confirms his mental picture about what the problem is, rather than seeking out information that might actually help build a picture and get to a resolution quicker. These communication problems result in a delayed diagnosis of the actual problem for the patient. And this is actually a really good example of a low-frequency, high-acuity event. It's perfect for medical simulation training because it gives people experience of this low-frequency event for the first time in simulation before it happens in a real OR. It's useful to also point out that the surgeon really showed some good behaviors in terms of dealing with the problem, delegating tasks, initiating the next set of actions to try and resolve the problem once it was identified.
And another really excellent thing to do, although we don't have time to discuss it, are debriefings. These haven't been as well studied, but the chance for the team to ask these questions, what did we do well today, what could we have done better, what don't we want ever to happen again, can really improve outcomes and also have the team coalesce as a team rather than just assigning blame. You know, doing something immediately in the post-case debriefing to make changes and improvement. So we don't have time to talk about handovers. Just to summarize, the ultimate goal is to build teams that are better at communication. That leads to better cooperation, coordination, appropriate cognition, and thinking about a shared mental model and respectful conflict resolution when that becomes necessary. So building better teams is one solution to providing optimal care and improving outcomes within an institution. But solutions without implementation strategies are destined to be failures, and it's certainly true that across the country, across the world, we're still learning a lot about the science of implementation. So the current state of affairs is that we've made a lot of progress, and we're probably now at the end of the beginning in this field. And by the way, this is an excellent area of research for those who are interested in publishing and academic careers in the operating rooms, and they love us in the cardiac surgical operating room. We are in our infancy relative to the military, the nuclear industry, the aviation industry with respect to studying these types of things. And there are departments of surgery that have hired teams of organizational psychologists and human factors engineers to begin to get at some of this. You'll see, if you look at your own literature, many publications are starting to come out. It's just a great field, a great opportunity for research as well as, making day-to-day changes. So thank you all for your attention. I'm really honored to have been here, and I hope you enjoyed it. Thank you.
Questions for Dr. NUSSMEIER? Dr. NUSSMEIER, thank you very much for a great presentation. Questions? Let me ask you this. Oh, go
I have
ahead.
a question. I'm here, right here.
I'm sorry.
In one of your lines, you said that in the OR, they should put their phones from ring to vibrate. But even vibrate is a distraction for that one person, though it doesn't distract everyone like a ring would be. Wouldn't it be a better policy to say, no phones in the room? They can't answer the phone anyhow. They have to wait until they get out.
Yeah, I mean, certainly there are institutions where the circulating nurse is assigned to manage all pages and all phone calls, and the phones are lined up in a corner on a desk, and that's one implementation strategy. Again, there are many implementation strategies kind of being tested, and each institution does it a little different, and that's the stage the field is at right now. Other questions?
We routinely use surgical checklists here at Houston Methodist Hospital and our system hospitals within the Houston Methodist system. Is this a standard pretty much everywhere now, or are there still places behind with regards to surgical checklist?
I think throughout the U.S. and throughout much of the world, it's becoming almost, completely standard. Converting that checklist to a more formal briefing or huddle where there's more detail and where every team member is participating. It's not just one physician and one nurse going through the checklist. And you discuss the case you're about to do, particularly, again, if the team's unfamiliar with each other, such as the videos I showed you, is way better than a checklist. But I would not say that every institution has gotten to that point yet. Certainly at the Mass General and the Brigham, they are at that point. At Duke, they had the mismatched heart transplant. They're certainly at that point. So lots of places at Mayo where Torrent, the cardiac surgeon who's now chief at Mass General, came from Mayo Clinic, they're there. But not every place is at a really good briefing, and fewer places are doing a really good debriefing after every case.
Dr. Ware?
I think, where this is most important is when new staff are introduced. For example, if a new surgeon comes in, we don't know them, we don't know their practice. A new anesthesiologist comes in, and more frequently new nurses come in. It makes the fear level go up, and we need to have, whenever someone new comes in, we should have a meeting with them. I remember, like, back in the 90s when I was practicing at Maryland, a new surgeon came in, and my introduction to him was over the scrub sink. I mean, that was it. And I didn't know how he liked to cannulate. I didn't know if he wanted a vent, so basically, I think it's a really good idea for any new person to come in. We should have, a meeting before with the perfusionist, the anesthesiologist, the nurses. This is how I expect to do my index cases, or, even the complicated cases. And another thing, I think that the debriefing you were saying at the end, usually if something goes smoothly, I think, in our haste to get cases turnover and all that stuff, we're not going to really have time to do that kind of thing. But it just seems like if it's a disaster case, that's when it probably should happen. But I think people are so exhausted at the end of that kind of thing. It ends up being a debriefing at M&M.
Well, the places that have implemented real debriefings, either after every case or like in England, there was a study, and in that institution, it was the same team worked together in the same room until they finished the schedule for that day. So that they did it at the end of the day. That doesn't usually work out as well here in the U.S. But they have generated measurable improvements. There's a private hospital in Pittsburgh area that has done that. Kulig, I think, is the first author of that paper, and really demonstrated improvements because team members may have thought of things as the case was ongoing that would actually be an improvement, but it just never gets discussed. It never gets implemented. So even if things seem to go pretty well, there may be some gains and some improvements to be made. And the thing about you were discussing a new surgeon coming in and what that surgeon might want or need. But remember, there's this whole team, and you're probably getting new nurses and new perfusionists all the time, not to mention, occasional new anesthesiologists. So it's not just the surgeon. That's the whole point of this. It's the whole team.
Again, thank you very much.
Thanks.